Living longer, living healthier, living better than ever before. Welcome to Mountain Pacific's Healthy Living for Life, a weekly series that gives you the information, education, and expert insight you need to become an active participant in today's ever-changing healthcare climate. Here now is today's program host.
America is seeing a sharp increase in the number of opioid-related deaths. Nearly half of all overdose deaths involve prescription opioids. This has forced a nationwide push to reduce the number of these types of deaths. Today we'll take a look at the issues leading to this nationwide epidemic, and along the way learn what's being done to curtail opioid abuse and misuse. Welcome to Healthy Living for Life, a show dedicated to helping you do just that. I'm Janet Whitmoyer. Stay tuned. Welcome back. My first guest is Dr. Philip Steele, a family practice sports medicine physician here in Helena. Thanks for joining us, Dr. Steele.
Thank you.
Okay. I wanted to start off by asking, why are so many people who are on opioids still in pain while on these powerful drugs?
Well, that's a great question. The problem is that many of these medications decrease the threshold at which you perceive pain. So simply speaking, if I were to pinch my hand right here and I pinch it lightly, I shouldn't feel any pain. But as I pinch it harder and harder and harder, at some point I'll perceive pain. What fentanyl and morphine and many of these medications do is lowers the threshold. So the amount of pinch that I need to pinch here to create pain changes. And so the more I prescribe an opioid medication, the lower my threshold to perceive pain is. And fentanyl is a horrible example of this. It's a medication that's made many Americans dependent on this stuff, because as physicians we're like, oh, you poor thing, you're in pain, let's give you more. And we're actually compounding the problem. We're actually making them more sensitive to pain, so that if we just briefly touch something or have pain shooting down our arm, we just barely touch them, they're like, oh my gosh, we need to help you. And as physicians, we got into being physicians because we want to help people, and we don't want you to suffer, so we give you more. And that's actually compounding the problem. And as a physician, we weren't taught about this. When I went to medical school, nobody even talked about this. I go to conferences and nobody mentions this. So it's really important as a physician and the public to be aware of this issue, that we're actually making the problem worse by prescribing these medications.
Okay, great. Can you tell us a little bit about what opioid-induced hyperalgesia is?
Well, that's essentially it.
Okay.
It's by using opioid medications for chronic pain, we're actually creating more pain in some of our patients. And it's thought to be only a small percentage of patients initially had this rare complication. But we're learning that more and more and more that this is a much higher percentage of the population. In my clinical practice, I see it all the time. People come to me, they're on fentanyl, they're on breakthrough OxyContin tablets, and they come in and I just barely touch them, or I just try to move them for an examination, and their pain's out of proportion to any of the problems they have. And so the physicians keep giving them more, and that's not the answer to this equation. The equation is fixed by getting them off of this medications completely.
Okay, so can you talk a little bit about how you would treat somebody and what the treatment would be to get them off of that? I can't imagine you just say no more.
Well, the problem is, patients come in and they say, I'm in pain, you want to take this away from me? The initial response is, are you crazy? And so I need more of this stuff. And so it's a paradigm shift. We have to educate our patients that pain is actually okay. When you have an operation, we say, oh, you need these pain medications because you're going to have pain post-procedure. Right. Well, what if we change the paradigm to say, oh, pain is good. You're going to have healing pain as part of this procedure. You're going to experience the healing pain symptoms after the procedure. So we need to change how we discuss and talk about pain. We can also, there's medications to help get people off pain. We can use long-acting methadone. We can use clonidine for some of the symptoms of withdrawal. There's naloxone, which is a medication to use for overdose and for dependency. So there's lots of medications that can be used, and under the care of a physician that's familiar with getting someone off this, you can use those medications. But the biggest part is just the sales pitch. I have to convince my patient that at the end of the day, if I get them off of these medications, they'll have less pain than they have currently, and that's a long, complicated subject. And the first time I meet a patient, they're like, oh, there's like no way that's going to happen. But as you continue to work with the patient, that's why I do a lot of nerve blocks and I do other procedures to try to get them to the point where they're using less and less of it. So we convince them that if I can get them off, they'll actually hurt less. And they start to see that, and they start to notice that they're feeling better. Realize that opioids decrease testosterone production. And women and men need testosterone to heal. If you have chronic opioid dependency, you're on chronic pain meds, your testosterone level goes down. So your healing potential decreases, you're depressed, sexual desire goes down, lots of things are depressed. Suicide rate go up, depression's huge, everything changes by being on opioids chronically. And so once they start coming off it, they notice that they're less depressed, they can become more active, they can start to go back to work, they can do many things. So a lot of people that are on chronic pain are habituated to the point where they just sit at home and do nothing. And so, studies looking at just active lifestyle versus antidepressant medications, which wins in terms of being more effective? Being outside in the sun, the babbling brook and the birds singing was more effective than antidepressants. So we need to start looking at changing the paradigm, how we speak about opioid dependency, how we talk about pain, and then how to get our patients active and so that they feel better, and then convince them that by doing so, they're going to improve the quality of their life.
Great information. So on the flip side of that, do you think that there is an option for opioids for some patients, or is that something that we should get away from prescribing altogether?
Well, there's a difference between acute pain and chronic pain. So you roll down the stairs and you break your leg. There's good evidence to support that short-term opioid use, 5 to 7 days, is not addicting, not low potential for addiction risk. And so we need to kind of convince our patients that we're going to give you this medication, and it's only for the acute onset of the pain. And then after 5 days, we're going to transition you to something else. We're going to start physical therapy. We're going to recommend acupuncture, maybe chiropractic care. We have all these other options, TINS units. There's lots of modalities that we could do. If you just cut them off with nothing to hope for, they're like, well, I need another doctor to give me a pill.
Okay. Oh, awesome. Well, that is really good information. So helps us to know when it's appropriate and then when other types of treatment are more appropriate for treating pain. So thank you very much, Dr. Steele, for being with us. We'll be right back to hear from the Department of Justice to learn what they're doing to reduce misuse and abuse. So here in Montana, stay tuned.